414 Patient Care Presentation. The patient I'm going to talk about during this presentation is a 58-year-old African American male who has a history of chronic kidney disease, CHF, and has an LVAD. He was admitted to the hospital for worsening shortness of breath, lower extremity edema, and increased abdominal girth. I included his race in this because African Americans are more likely to have heart failure and are also more likely to have symptoms at an earlier age. So his medical history is as follows. He has type 2 diabetes, gout, hypertension, non-ischemic cardiomyopathy, and end-stage renal disease. His surgical history is he had an LVAD placement back in 2017, along with a pacemaker placed. So some pertinent physical examination findings that I have are he is AFib on the monitor. He has mean arterial pressures in about the 50s, despite his fluid volume excess. He's had a weight gain of over 10 pounds in the past couple weeks. He has bilateral crackles, +1 pitting edema in his upper extremities and +2 pitting in his lower. He has a PD catheter site that is currently not in use due to a possible infection, a right chest wall testeo for his hemodialysis, and lastly, he has an LVAD driveline exit site in his abdomen, and it has a weekly dressing change kit in place. He wears a CPAP at night while sleeping due to sleep apnea. His EF was 10 to 15%, and that was found by echo. So some pertinent labs were sodium was 129, potassium was 3.8, calcium 9.1, his BUN was 34, creatinine 8.27, and hemoglobin 8.3. So the following medications listed on the slide are the medications that he was on. So we had furosemide, and he's on that just for his fluid excess. Amiodarone because of AFib. He was on midodrine, and this was used to help increase his MAPs because they were very low. He was on a heparin drip to just help reduce blood clots, and he was on digoxin to improve the pumping ability of his heart. So according to Pilacori and his colleagues, these are common prescribed heart failure drugs. They help improve symptoms, functional capacity, and quality of life. Some other pharmacological interventions for heart failure could include vasodilators, ACE inhibitors, mineral corticoid receptor antagonists such as aldactone, and then some beta blockers. So the overall plan of care for my patient was to remove the excess fluid and to increase his mean arterial pressures. We did this by having him on a continuous heart rate monitor to monitor his AFib. We monitored his vitals every 4 hours to determine if our interventions were working or not. He was placed on a cardiac diet with a 1.5 liter fluid restriction. We monitored his intake and output very closely to avoid excess fluid intake. We weighed him in the morning and compared each weight with the previous weight to see if our interventions were working or not, and if we needed to give suggestions to the physicians. We assessed his lung sounds, and this is important just to determine if he is holding fluid and if he had crackles and if they were improving or not. We monitored for worsening edema, and we administered his prescribed medications that I mentioned before. And whenever he was in bed, he either had his SEDs, and then when he was out of bed, we put on bilateral lower extremity ACE wraps just to help with fluid retention in his legs. So after doing everything in our plan of care for my patient, he continued to have edema, low MAPs, and increasing weight gain. He said he was feeling worse than before. During our shift, he did go to hemodialysis. He said it helped him feel a little better, but He didn't get as much fluid off as he should have. When he returned to our floor, we notified the MP and suggested something further needed to be done. The MP put in an order for a UF, which is ultrafiltration, because our patients seemed to be unresponsive to the diuretics, which is why that form of therapy was chosen. UF works by rapidly circulating blood through a special filter. It sheds excess water and salt through aquapheresis, and then it returns to the patient, and it can be done at the bedside. And this was from an article by Houston, Kathaya, Kim, and Zachariah in 2015. So this is a bit of a summary of my algorithm that is to come on the next slide. I'm going to talk about the overall treatment of fluid volume overload in CHF patients. I would say the number one pharmacological treatment for fluid volume overload is diuretics. According to Mullins, Damon, Rasachika, and Coates, the purpose of diuretics is to achieve euvolemia. The degree of volume overload and diuretic response will determine the success of the therapy. So another pharmacological therapy Mullins and his colleagues suggest are ACE inhibitors. ACE inhibitors have been shown in many studies to reduce morbidity and mortality in patients with heart failure with a reduced EF with mild, moderate, or severe symptoms, with or without coronary artery disease. ARBs are also another pharmacological intervention, and they have been shown to also reduce the mortality of heart failure patients with a low EF as well. Long-term therapy with ARBs in patients with heart failure with reduced EFs produce hemodynamics and neurohormonal effects, according to, like I said, Mullins and his colleagues. According to Arujo, Nobrega, and Garcia, nursing interventions are significant because they provide clear and objective information regarding the health status and prognosis of the client. They also help to educate the patient on their disease process, which in turn encourages self-care and customizes treatment regimens to the lifestyle of the patient. So above I have the nursing interventions listed. So monitor weight trends, monitor eyes and nose strictly, compression stockings, monitor their vitals, and assess their breath sounds for presence of crackles. So this slide shows my CHF with fluid volume overload algorithm. On the one side, we have assessment findings for a patient who has fluid volume overload with CHF, and on the other, we just have a CHF patient without fluid excess. Both of the sides show nursing interventions and medications that are used with CHF. So a little summary, my patient came in for a CHF exacerbation. He had excessive weight gain despite using his prescribed diuretics. His doses were changed throughout his hospital stay. He did go to hemodialysis, but it wasn't as successful as it should have been. Throughout his stay, he had really low MAPs in like about the 50s. We gave him midodrine to help increase those MAPs. Our final attempt to remove fluid was done by ultrafiltration, and it did end up removing over 1.5 liters of fluid. He also got his PD catheter that was infected removed through surgery, but after his surgery he was transferred to the CVICU because he did not come out of the anesthesia well. And lastly, these are my references.